Welcome everyone to another POCUS Power Hour where we do our evening webinars on interesting subjects in the world of point of care ultrasound. Tonight, as a vascular surgeon, I am thrilled to be joined by two esteemed colleagues from the other side of the curtain, if you will, the people that cause all of my hypotension and complications in the operating room. Esteemed anesthesiologists, Dr. Durick and Dr. Samet, both of these guys have incredible backgrounds. I will let them introduce themselves. They're incredible underachievers because they're still waiting in their career to accomplish something. And I think you're going to find they're actually amazing anesthesiologists with very diverse backgrounds, with incredible experience that span the globe of anesthesia, but as well with specific expertise in point of care ultrasound. And in their particular backgrounds, will demonstrate for us the breadth of utility of point of care ultrasound in the use of anesthesia. You know, we hope tonight that this will be something that if you're not using point of care ultrasound for the variety of use cases that we're talking about tonight, you will be, or at least inspired to explore it and then follow up with these two gentlemen who are incredible teachers. Thomas, why don't you go first? I think you're the senior gentleman of the two.
I am. Thank you. So my name is Tom Durick. I'm an associate professor of anesthesia at The Ohio State University, Wexner Medical Center, College of Medicine. That's how you have to say it. We talked about that. You have to say the, which is actually copyrighted. My background is diverse. I spent 30 years as a private practice anesthesiologist before coming to Ohio State. So it was a real culture shock going to an academic environment. And the last 21 years before I went to Ohio State, I was in the San Francisco Bay Area, and I helped run and start ambulatory surgery centers almost those entire 21 years, to the point where I took over billing offices and ran the financial side of surgery centers. So quite a bit of breadth in the ASC market, and did my first ultrasound guided nerve block back in 2004 at the prompting of an ASA meeting where somebody's talking about this newfangled technology, ultrasound. And I remember specifically saying, this is never going to work. I can't take an extra 15 minutes to do a block. My surgeons are going to kill me. So again, John, that fear. And as it turned out, it was quite the opposite. And then gastric ultrasound just came about as a need about 9 years ago, where I was practicing again in the Bay Area. So I do a lot of teaching. We have residents right now. My private practice DNA still persists through everything that I do. I'm now the clinical operations manager for Outpatient Care New Albany Surgery Center, the first surgery center that Ohio State opened. And I delve a lot into the efficiency and keeping patients safe at our surgery centers.
You know, Tom, I really want to get to know those surgeons that you were working with, because I haven't learned how to inspire fear into an anesthesiologist. I don't think I've ever been able to accomplish that. So I need to learn that trick. All
I'll
right,
teach
Ron.
you.
You got to teach me that. All right, Ron, how about you? Tell them about your background.
So my name is Ron Samet. I'm an associate professor of anesthesiology here at the R. Adams Cowley Shock Trauma Center at the University of Maryland. I came in 2005 as a trauma anesthesia fellow, and during that year is really when the explosion of ultrasound-guided regional anesthesia began to show up. And for me, particularly the patients that we had, the trauma patients that we had that were experiencing so much pain, if there was a way that we could provide them with regional anesthetics in a more effective way, in a much more accurate way, that was my main objective. So during that year, I spent a little time at one of our sister hospitals learning ultrasound-guided regional anesthesia. Came back here and did a lot of self-learning on my own. I did not do a regional anesthesia fellowship, but then using the ultrasound skills that I picked up and reading a lot, looking at a lot of case reports, looking at a bunch of, old anatomy textbooks, I developed and created the program in regional anesthesia here at the University of Maryland. Over the course of a few years, we then expanded to regional anesthesia and acute pain medicine. And then over the last 20 years or so, I have then ventured into more not only interventional techniques, both vascular access and regional anesthesia, but also a lot of diagnostics. So POCUS cardiac, POCUS lung, POCUS gastric, POCUS fast. And it's been an incredible time here, but the objective of really trying to not only do it myself for our trauma patients, but also to try and teach it to our residents and our fellows, and begin to expand the way we take care of our trauma patients has been really revolutionary based on ultrasound. So excited to be here.
Yeah, very impressive background, both of you. And a couple of quick questions. You failed to mention, Ron, you also have joint appointments in the School of Nursing and Bioengineering. So you clearly have a very diversified and having a huge impact on the people in the University of Maryland. And truth, full transparency to everyone, Ron and I are both in the same system. I'm a professor also at the University of Maryland, although we work at different places. We're a kindred spirit. And Tom, a question I had for you is, how'd you go from the Barrow Institute, maybe one of the most prestigious neuroscience places in training, into being the guy doing ambulatory surgery stuff? How did that transition actually happen?
It happened just by default because when I got my very first job 35 plus years ago, so I am the old guy, you can tell by all the gray hair on my head. The hospital I started at was looking to recruit a neurosurgeon. And they said, wow, this guy's got a neuroanesthesia fellowship. This is a match made in heaven. And it was. We did a lot of neuro cases at a smaller hospital. We probably shouldn't have been doing at the time. Circumstances changed, economics changed. And I found myself in the Bay Area because I realized when I was working locums, I could work from anywhere. And a friend of mine said, hey, have you ever worked at a surgery center? No, didn't really know what they were. Started working at the surgery center and just fell in love with the pace, the speed, and immediately found myself trying to do things more efficiently. You know, the neuro cases are the polar opposite. You have one patient for what feels like 100 hours, and you can do some really good things whether you're trying to decrease their, cerebral spinal fluid and their intracranial pressures, whether it's ventilation and vascular, putting spinal drains in. But I fell in love with the speed, with the efficiency, and the rapidity of the private practice. And I luckily fell into an almost pure orthopedic practice in Oakland with a bunch of really good surgeons and great staff, and just found my love, my passion in doing ambulatory. So it's kind of by default, just leaving that hospital with economic circumstances that made me do that.
Interesting. Well, actually, why don't we start here? Because obviously in the world of trauma, efficiency actually matters tremendously. And you've talked about efficiency in terms of how you turn over cases and make the economics of this work. A lot of the beef sometimes about adding ultrasound to whatever it is we're doing is, quote, the time that it takes actually to do that. Maybe both of you could speak in general terms and maybe under specific use cases where there's this kind of misnomer, if you will, that ultrasound actually slows things down, instead has just the opposite. Ron, why don't you start from a trauma perspective and tell us how you think it actually increases efficiency rather than decreases efficiency?
Yeah, ultimately with our trauma patients, one of the most important things is not only managing the airway, ensuring that they're breathing, bilateral breath sounds, focusing on whether or not there's a positive fast, because that ultimately triages a patient. If a patient's hypotensive and has a positive fast, they go directly to the operating room. They don't go to imaging. So obviously there's a huge advantage to using ultrasound for those particular patients. But in the anesthesia world in particular, it's really ensuring that you have bilateral lung sliding, making sure that both lungs are up. There isn't a pneumothorax. You can quickly look over with the surgeons also as to whether or not there's continuous bleeding. For vascular access, I mean, it's kind of a no-brainer. For arterial lines, putting it with an ultrasound has been much faster than being able to just do it blindly, especially if someone does end up hitting the vessel and then it either goes into spasm or they go through and through the vessel, trying to get another arterial line into that same extremity or going to a different extremity. So having an ultrasound device right there in our trauma bays makes a huge difference in terms of being able to put lines in. And obviously when you go back into the operating room, these patients can often be significantly hypovolemic. So getting a central line in or getting another arterial line in or bigger access, having ultrasound really changes our ability to take care of these patients in a rapid and efficient manner.
So from an efficiency perspective, I think it's gotten to the point now, we've evolved where if you put a central line in without ultrasound, you better have a really good reason why you did it. I think that's probably true. But from an arterial line perspective, what we typically see is people try first, and if they can't get it, they go to get the ultrasound. Do you find that in your institution, you do ultrasound first and start there?
I think it's still provider dependent, and sometimes people like to be able to do things blindly and hopefully get it in. There's somewhat of a satisfaction if you're able to do that. And using ultrasound might be a crutch that some people just feel that they don't want to do. I will say that, the one line that I will say that we don't often use ultrasound is a blind subclavian. Those insertions, when they're much closer to the clavicle and the insonation or the angle on which you would have to use the ultrasound would be different. We don't often use for immediate or emergent subclavian lines unless you go much more lateral and able to see the vessels nicely and come in further away from the lung. But for the most part, any IJs or femoral lines will get an ultrasound guided line. Absolutely.
So from efficiency perspective, Tom, in your surgery centers, what do you typically see? How are you using ultrasound to improve, if you will, turnover and getting the case started? Because the surgeon's over there like me, tapping his foot, going, let's go, let's go, let's go.
I want to just back up and kind of echo what Ron said. So I do use ultrasound when I was putting A lines in, which I don't anymore because I'm at the surgery center. I use it every time for two reasons. And the reason, again, not trying to make this a commercial for Butterfly, the biplane view was a game changer. When you have that 85-year-old lady with that artery that looks like a pencil lead, and you really only have one chance, like Ron was saying on there, I want to give myself the best chance of first pass success on that. Because yeah, I used to like to try and do it by feel, but I also have to remember, I teach our residents, every time you take that needle out, number one, you expose yourself to a blood contaminated hollow bore needle. So it not only is riskier for you as the person putting the line in, it's riskier for your patient because now you have to stick them again. And time is of the essence on some of these cases, especially where Ron works. Time really is of the essence when you're trying to get labs or get an arterial line in. And if somebody does go through and through, then I taught them to use that biplane so you could see both your needle and your guide wire going in. And if you see it on the posterior part of the artery, you can keep that needle in place, pull it back till you know you're inside the vessel. You don't need to give blood return. Drop it down, see your guide wire, and then thread your catheter off over that. You can save an A line without having to stick them again and save a lot of time. From a surgery center standpoint, and it was Dr. Joseph Neal at Virginia Mason at an ASA meeting decades ago talking about this newfangled ultrasound. And normally we all know you go to these big meetings and whenever the lecturer finishes, people are all gathering around and, trying to get their opinion. And nobody went up to this guy. And I went up and I was like, hey, I'm Tom Durick. I'm the surgery center in Oakland. Ultrasound, man, I don't know. Like we were talking before, I just can't imagine adding 15 minutes, mucking around with this ultrasound, trying to get a block. And he said, mark my words, there will be nerve blocks that we don't even know about that we can do with ultrasound. It'll make you faster. You may never miss a nerve block again. And I remember saying, well, I'm pretty good at nerve blocks. He said, what's the block you do the most? I said, brachial plexus. What's your success rate? I said, 98.2%. He goes, wow, you know it to the decimal point. I said, yep, I've been tracking them for 6 years. He said, how come it's not 100%? And it was like this gut punch. And it hit me like, for that one patient that you don't get it, that's 100% failure on them. So yeah, my blocks did get faster. They're a matter of a couple minutes, and Ron can attest to this when you're trying to do blocks in a trauma situation, having that block ahead of time and not having to give all those narcotics and all the other anesthetics you need that's going to drop their blood pressure. And the same holds true in the surgery center. You can pop your block in a couple of minutes. Nobody's waiting for you. While they're turning the room over, you can throw your brachial plexus, your adductor canal, your popliteal block, whatever you're doing, PEX block, tap block. You can throw that block in a matter of a couple minutes. And now that makes the entire anesthetic course safer, simpler, and better for the patient. And it's also a satisfier for the surgeon because now you're not getting called from a patient having post-op pain afterwards.
Let me just follow up on what Tom just shared. And I think this is probably one of the most important things about ultrasound. This happens very routinely. We bring a patient down to the operating room, may have had multiple procedures, may have had previous arterial lines. And either the anesthesia provider, the nurse anesthetist, the anesthesiologist, the resident, whoever it is, feels for a good pulse. And they could feel a pulse. And they get that. They don't use ultrasound. They blindly stick it. They get some blood flow. They thread their guide wire in. They thread the catheter in. They connect it, and there's no waveform. And they cannot figure out what happened. And the truth be told is they're actually in the vessel. But had they used ultrasound and scanned the vessel proximally, they would have appreciated that vessel already was thrombosed proximally. And so what they're actually feeling in the radial pulse is retrograde from the ulnar. And so, yes, they could feel the pulse, they could access it, they get some blood return, but when they thread the catheter, it's kind of useless as an arterial line because the radial artery itself is thrombosed. Being able to scan proximally, distally gives you so much more information. I'll give another example. Tom was just saying that his 98.2% in brachial plexus blocks, that is a number, and you're never going to hit 100%. You're never going to hit 100% unless you scan the patient and you know where all those branches of the brachial plexus are. There is anatomical variation in some patients where they're C5 nerve root is sitting in their anterior scalene muscle. It happened to one of our surgeons. One of our surgeons went to our surgery center. They got a nerve block. Everything looked perfect, even with ultrasound. But they didn't scan proximally and distally to appreciate that one of the nerves actually came off the brachial plexus higher up. And so they needed a repeat scan, but now with ultrasound, you're able to do that. You can go repeat scan and then actually put local anesthetic directly around the C5 nerve root. And then the patient had a full block. So being able to modify, we used to get taught exactly where to put our needle in when we did an IJ insertion. We used to be taught that if you want to do a good popliteal block, you go 7 centimeters above the popliteal crease.
Exactly.
You don't need to do that. You need to just scan with ultrasound, proximally, distantly, figure out where the best place to do a specific block is. And it doesn't have to be based on the blind landmarks that we used previously. It could be anywhere you really identify those particular structures. And now you have a roadmap yourself of where you want to put your target.
Have we gotten to the point now that everybody's just using ultrasound for regional blocks? I mean, is that now, a standard? Would you guys say it's an anomaly that people aren't at this point?
There are certain, or maybe you can talk to them.
I mean, I would think it is. I think it has been for some time, for exactly what Ron was just saying. You can't always go with nerve stimulation. You can't always assume that if you go on the medial border of a lateral head of the sternocleidomastoid, it's going to be there every time. You can't always say, oh, I know exactly where this block is. I've seen those same things. I've seen where you've had, one of the nerves in the bicep femoris and you had no idea and you would have missed it. So now your patient's going through an anesthetic without the benefit of the block. You're taking all the medical legal risk and your patient's not getting the benefit of the block. So yeah, I would actually say it's below the standard of care to not use ultrasound for regional anesthesia right now, because how many times, Ron, have you seen you're going to do a brachial plexus block and there's a big old aberrant branch of an artery going right where you thought you were going to go? And every time I would see that, I would go, I don't know how many times that the anesthesia guys were protecting me because I should have hit that when I was just using nerve stimulator, and you don't. So yeah, I do think it's the standard of care and should be.
Yeah. For me as well, I think it's pretty much the standard of care. Some people will also use nerve stim for some other safety concerns that they have. But to go back to efficiency, it used to take us some of these blocks were fishing expeditions. You'd be putting your needle in a bunch of different places to try and find it, and then with nerve stim, you got exactly where you wanted to be. You dialed your milliamperage to 0.2 to 0.5. You wanted your perfect, and then you had to inject all your local anesthetic. The benefit of ultrasound, aside from showing you exactly where to go, is that you could put a little local on top, little local on bottom, a little local on each side. It gives you the ability to really create that donut, which is ultimately the goal of trying to get a nerve block done to be successful, is to have local anesthetic around and that goes into the nerve. And so putting all your local in one specific place and hoping that it surrounds a particular area doesn't make any sense anymore. And I think it's actually safer, because in the old days, we used to probably stick the nerve a bunch more times than what we do currently. You could see the nerve, you could put your needle, you could advance it in real time. I mean, it'd be hard pressed for me to hear any kind of justification to not use ultrasound in nerve blocks.
Yeah, I used to call that the Stevie Wonder block. It was this.
Yeah, exactly.
They're doing this and hoping that it works. And hope is not a strategy, right?
It's never a
Talk a little
plan.
bit about, before we move off the blocks, the donut sign that you're looking for. So for those that are not familiar with that, you mentioned that. What exactly is that for those that are not familiar with that?
Yeah, so ultimately the understanding that we have is that if you want to if you want a nerve block to work, you have to have local anesthetic actually diffuse into the nerve, block the sodium channels in order so that that motor sensory block actually works. The best way to do that is to make sure that the local anesthetic, no matter how good your picture is, no matter how good you are with nerve stim, if your local anesthetic is not surrounding the nerve, if it's sitting in a muscle, if it's an injection in a fascial plane, but it doesn't actually approximate the nerve, you're not going to get a block. So for particular nerves, the femoral nerve, the sciatic nerve, the popliteal fossa, the infraclavicular, brachial plexus, and those particular chords of the brachial plexus, you have to get local anesthetic to surround the particular nerves for the blocks to work. And using ultrasound, you actually see the nerves, you see your local anesthetic infiltration. You should be able to be confident that you're going to approximate 100% with your block.
So,
And John,
yeah, go ahead.
I just want to go back to the efficiency because I realized I never answered that. For me, the biggest efficiency, especially with gastric ultrasound in an ambulatory surgery center, is preventing those case cancellations and more importantly, those case delays. Patient comes in at noon, cataract case, everybody's, oh, it's just a cataract. You're just going to give a little bit of this, a little bit of that. With the proliferation of GLP-1s right now, so many patients are on them. Some of them don't get a message to stop their GLP-1s. The patient ate last night, they drank liquids this morning, and a lot of places have an automatic either hard stop, 2 hours, 4 hours. And now that patient for that 1 o'clock cataract can't go till 3 or 4 o'clock. It's the 4 o'clock. The surgeon's busy. Now you're getting overtime for your staff. The patient's unhappy. They have ride issues on there. You can do a gastric ultrasound on that patient because in most patients, not that 85-year-old, in most patients are coming in for upper endoscopy, colonoscopy, shoulder surgeries. Most healthy patients are going to clear liquids out of their stomach in less than 15 minutes. So we have that kind of arbitrary 2-hour window. You can do a gastric ultrasound, turn them right lateral decubitus, head up, do a gastric ultrasound, and unless they've had some sort of gastric surgery or have some other contraindication of doing it, with pretty high certainty, know that stomach is empty, and then you can proceed safely with that case and not have all of those inefficient delays and cancellations. Because when you start canceling a patient, I call this the quiet discharge. They discharge you from their practice. They're not happy that they didn't get their case done there, so they're going to go to your competitor down the street. And what are they going to tell you? Oh, Dr. Martin's practice, we see this all the time. We get all kind of patients come over here from there. So now they've already set the bar lower for your practice, which makes it easier for them to exceed it. And then all those secondary, tertiary procedures, the carpal tunnel, the total knee, the shoulder replacement that patient's going to have, you lose all of those. You never knew that. So to me, gastric ultrasound, all those things Ron was talking about, being able to do a good, quick, efficient block, not causing delays and cancellations, not only for the patient, but for your providers, prevents all of those quiet discharges from your own people.
So let's jump into that. I was going to get to that later, but you've opened that Pandora's box because I don't think gastric ultrasound is a skill set that most anesthesiologists have right now. I mean, I think that they're pretty comfortable with using ultrasound for blocks. I think that's common. They use it for line placement. I think both of those things are common. But for gastric ultrasound, it's not. So why don't we, at least for people that aren't familiar with that, walk through quickly what the technique is? Do you measure exactly how much is in there, or do you guess? And has the government, and because I know there's some recent ASA recommendations around gastric ultrasound as well. Maybe we should go into that for the folks here.
For me, because of where I work right now in an ambulatory surgery center that does a lot of GI cases, gastric ultrasound obviously is very important. One of our surgeons will do 15 or 16 upper endoscopies in a day. And we have a lot of our specialists who do a lot of upper endoscopies. So you don't want that stomach to be full for obviously the reasons that there is that potential for aspiration. And Ron and we were all talking ahead of time just how challenging it really is to have a patient aspirate, but it's still that fear that we get in the anesthesia that's beating us in training. The gastric ultrasound, you're right. It's not adopted by, I would say, the vast majority of anesthesiologists. I've done grand rounds at Ohio State, I think 3 times right now. And this last time is where it really finally kicked into people. And I actually had people that I never thought would reach out to me. It's like, hey, I really do want to learn this. How do I learn it? I think it's a pretty quick learning curve because you have a really good marker. You have the medial border of the liver in there. So you're going to turn your patient in the right lateral decubitus, unless they have complete situs inversus. You want to get all of those fluids, whatever is in the body and the fundus, going into the antrum, the smallest part, that funnel of the stomach in there. So by turning them right lateral decubitus, head up a little bit, 45 degrees, whatever's in that stomach, you're going to funnel it down there. You place your probe midline, so it's right in line with the sternum. You start right below the sternum. I tend to use a curvilinear probe. In skinny people, you can use a regular linear probe. And the stomach is going to live in that superior portion right at the medial border of the liver. So it's usually, in most patients, quite easy to see. You can see the difference once you get very quick and good at it. The ultrasound is usually a less than 30-second process. And usually you will measure it. A lot of times you can just do the quick eyeball and do a grade 0, grade 1, grade 2 and say, yep, that stomach is a little bullseye. That's an empty stomach. There's nothing to measure. You can see there's clear liquids in there. I want to know how much that is. Is it going to be above 150 cc's, which our current literature tells us does increase the chance of aspiration? If there's solids, then volume doesn't matter. You're empty or you're not. You're either pregnant or you're not. So a little bit of solid, you're still full stomach. we don't normally make that an absolute, hard stop for doing an upper endoscopy, because our surgeons are going to put that scope in there, or our GI docs will put that scope in. And if there is a lot of food in there, then we're going to abort. If there's a tiny bit of food, they just simply keep it in view. And there's so many times where I've done a gastric ultrasound and I'll go in and tell our GI doc, hey, I think there's a little bit of late solids in there. Just be careful when you go in. And then they will call me in and say, check the screen out, and there'll be a little bit of late solids in there. So it's been a really good corollary. The only time I missed recently was I thought a patient had late solids in her stomach, and it turns out she had multiple gastric polyps, which look like late solids. So it does become an efficiency. It's not keeping those patients waiting. There are multiple places through the ASA, through ASRA, through gastricultrasound.org that you can go to learn this, and even if you want to get certified. I don't think it's a steep learning curve. You just have to know when it works and when it doesn't.
So what are they doing at Maryland, Ron? How do you do the trauma? Because no trauma patient is going to sit back and say, I'm going to be NPO before I have my car accident.
Correct. They also don't necessarily get reference to our institution in, as Tom was referring to before. Unfortunately, if you end up in the trauma center, it wasn't something that was particularly planned. I would add a couple of things in my experience. Obviously, Tom might have a lot more experience with gastric ultrasound, especially in the ambulatory center. What he's really looking for, as he just explained, is whether or not the stomach is empty, in which case you can proceed, even in a patient that may have broken all of the MPO guidelines, or maybe on medications that might suggest gastroparesis, might have diabetes, those kind of things. In our patient population, obviously, we assume everyone's a full stomach, right? Whether or not we know that information, and also the fact that they had a trauma, they may get opioids. The trauma itself might cause some gastroparesis. So we just assume everyone's a full stomach. Now, there definitely are circumstances where even if it's not the acute trauma, but they might be coming in the next day. And there are circumstances where patients on the complete reverse side may have been NPO for 24 hours, but still might have a full stomach because they've been on opioids, because of various different, issues related to their trauma. And so there is some element of value in some of those patients doing a gastric ultrasound. Ultimately, for us, since we assume everyone is a full stomach, we tend to proceed with the airways because nothing's really particularly elective here. Most of the cases are either emergent or urgent. And so we just take our normal precautions in terms of reducing aspiration risk. But having that information is helpful. The only other thing I would say for me particularly has been the learning curve can be relatively easy in terms of doing more gastric ultrasound. However, there still are some patients, some of the obese patients, some of the more challenging patients, you don't always get the same window. So if you're used to doing ultrasound guided vascular access, used to doing ultrasound guided regional anesthesia and being able to see the sciatic nerve and the popliteal fossa, see the femoral nerve, it's not going to be, you're not going to have that same success rate of being able to see the stomach, even in right lateral decubitus, because just some patients they're hard windows to actually appreciate. And you also have to learn how to appreciate the difference between the stomach and the colon. And that is a really, really important feature, because if you're looking at the colon and that looks relatively empty, but you didn't really appreciate the antrum of the stomach, you definitely can get fooled.
I think one of the most important points about this is you're not going to get good at this unless you do it. I mean, one of the
Correct.
beauties of the trauma patients are that you got a group of people that actually may have a full stomach. You can get used to looking at what full looks like and what empty looks like. So
Yeah.
I think that's the key part of this, is that don't wait until that just unusual circumstance where, oh, I'm going to have to do an ultrasound to see. Do it a lot. It doesn't take that long. It's very quick. You can get used to recognizing with your eyes that ocular mental reflex of, I know what that is, I know what it looks like, or I don't know what that is. I can't tell whether that's stomach or colon. I know that that's a situation be different. But I think the important point for residents that were around, that you get used to doing this frequently, then you'll get good at it.
Absolutely.
I want to make sure that people have the opportunity also to post some questions. And there was one in the Q&A, which is interesting, that we mentioned that maybe we've gotten to the point where vascular access and nerve blocks, ultrasound is a standard of care. What do you think is going to be the next, and we'll get into some other use cases, standard of care issue for point of care ultrasound for anesthesia?
Wow. Ron, take that one.
Well, I can just say this, I'll give you an example today, literally, and it goes back to the efficiency that Tom mentioned. It goes back to appreciating what ultrasound is a tool. It's a tool for us to answer questions that we have anyway, and it's probably a better tool than many of our other. So we had a case today where one of my colleagues put in a central line. It went completely uncomplicated, but the typical protocol here is to get an X-ray. So you have a patient who came in, is getting a lower extremity procedure, needed a central line. They got a central line, and now we got to wait. We got to call radiology. They got to come in and get an X-ray to ensure that there's no pneumothorax and the line's in a good placement. Well, the line was placed with ultrasound, and so as the CRNA was suturing in the line, I just used the same ultrasound, came underneath the drapes, looked at both sides of the lungs, and there's no pneumothorax here. You could switch over to a phased array probe. So that was with the linear probe, switch over to phased array probe, or with the butterfly, you could just turn it to the phased array. And just look at the heart, and you can actually see that the line is sitting right at in the right atrium. So the information that you're looking for, you just solved with the same technology that you had to put the line in, and you can proceed with the case. There's no reason to then get a chest X-ray in that particular case. And I think understanding those kind of things, understanding if you're worried about pneumothorax, I think lung ultrasound is probably going to become much more prevalent. Understanding when you have a little bit of a pleural effusion, whether you have overload, whether you have a pneumothorax, identifying the size of the pneumothorax. This is it, like you said, you have to train, you have to practice, you have to do as many scans as you possibly can. When I got my first butterfly, I actually brought it home. I lined up a bunch of my kids and told them we're just going to start scanning everything. And they were young at the time, so it was okay. But yeah, the more you scan yourself, scan your friends, scan your colleagues, scan your co-residents, whoever it is, I think you'll begin to appreciate how powerful this tool is that's in your hand.
So we'll jump to something again. I think we'll take the flow, but I think the value of handheld ultrasound, butterfly or not, pick your choice. I obviously am a homer here, and I think the value of having a single probe that can do everything makes a ton of sense. The OR doesn't have 18 ultrasound machines floating around. There's not an ultrasound machine for every single room. How do you guys deal with that in your place? Is it time now to make a statement as an anesthesiologist? I want an ultrasound. This was going to be my question at the end. In my cart, you got a Mac 3 blade. You don't need to use it every time, but you sometimes do. I would argue that there's probably more uses for the ultrasound than the Mac 3 blade or the McGill forceps, or pick any of the other goofy things you guys keep in that cart that are never used, than there is for an ultrasound, which nowadays with the cost of devices is affordable enough that it makes sense it's in an anesthesia cart. How do we get to that point, and do you guys see that happening, and how could we drive that within an institution? Because I would agree, I don't like waiting for an ultrasound machine to come in the room. And I'll throw one more at you that you guys won't mention in a minute after we get through this conversation, because I think actually it's an incredibly valuable bladder scanner. We guess on how much is in the bladder. You got a 75-year-old man come in, and now when I do my standard thing, guys, I do an ultrasound of the bladder the first thing I do before I start any of my vascular cases. And the nurses look at me and why? He went to the bathroom before he came in here. And I said, because he's 75 and that he said he went to the bathroom doesn't mean anything. And I got funny looks until the first patient I had that had 600 cc's in their bladder. And the guy that said he just went to the bathroom, they don't give me any grief anymore. They understand why I do it. And so, have then that versatility to make ultrasound part of that advanced tool. I don't understand yet why it's not in every anesthesia card, and maybe you guys can help me understand that. And what do we have to do to make that actually happen?
So, as we talked earlier, we kind of did make that happen at Ohio State at the James Cancer Hospital. We made that happen about 3 or 4 years ago, where it was known that waiting for ultrasound is just not acceptable in some of these lengthy procedures. Ron said putting a central line. It is the standard, putting a central line in. I think that all ultrasounds, give yourself the best chance of first pass success. Give yourself the best chance of having to do this one time, saving time. You're putting an A-line in a patient. If that patient's under anesthesia, if you've already put them asleep and you're doing your A-line post-intubation, now there's no stimulation on that patient. So you run all this risk of having anesthesia, all the hypotension while you're trying to get an A-line. So give yourself every opportunity. So we did that initiative about 4 years ago, trying to get an ultrasound in every single room. And we did go with the butterflies. The disadvantage of not having that instant access, and like at our surgery center, if you only have one curvilinear probe, but you have 2 machines, you basically have 1 machine. Because if they're using that machine in the OR to do some scan in the surgery, now you have no machines. And now everybody waits. So if I'm waiting and I can't do my block or I can't do my ultrasound, it holds up my other rooms that I'm supervising. The other correlate of that, and I'm glad you mentioned that, was the bladder scan. I use that all the time for our bladder for our post-op patients. We do a lot of urogyne and gynae surgeries, and the surgeon won't let them go home until they pee. And there has to be so much in the bladder. Well, let's look at it as soon as they get out. You empty the bladder and there's still 400 in there, they're not going to pee. So instead of keeping them in recovery for 4 more hours, or after the spinal block for their total hip or whatever, keeping them for 4 more hours, you know they're not going to pee. You're still going to put a Foley in and send them home, but you just didn't waste 4 hours of your staff's time, your overtime, your patient's time. You can pay for that handheld ultrasound in about a week by cutting that overtime of your staff and improve your patient and your surgeon satisfaction.
Where are you with that at Maryland? I know we don't have one in one of the rooms yet, but
Yeah, so Tom brings up a lot of great points, and so do you. The only caveat I had, and to be very honest, is that there's a very significant difference between interventional and diagnostics, right? Interventional, you're dealing with needles, you're dealing with blood, you're dealing with sterile dressings and all those kind of and sterile ultrasound probe covers. So it's a little bit more challenging to have even a handheld device because ultimately, where is that connected to? If it's connected to an iPad, to an iPhone, or to other kind of mobile phone, it becomes problematic in terms of cleaning it, right? So it is incredibly versatile. So you could do your A-line, you could do your block, you could scan the lungs, you could scan the heart, but ultimately, with interventional, it's a little bit more challenging to keep these probes appropriately cleaned for infection control. And obviously in our trauma center, a lot of these patients come in, they may have come from a bad motor vehicle accident, they may have open wounds already. So we have to be very conscientious about how we're utilizing ultrasound in those kind of circumstances and ensuring that we're doing this safely. From a diagnostic standpoint, yeah, having a handheld device is phenomenal. Having ultrasound is phenomenal. But obviously, doing a quick scan and taking it off the patient without it really getting contaminated and dirty is a lot easier. I think ultimately we are going to go at some point to having an ultrasound in every OR, in every trauma bay. And whether that's a handheld or whether that comes down from the ceiling or whether it's connected to the anesthesia machine, it's part and parcel of our practice, and we have to do that. I think Tom's done some interesting studies or work in terms of showing how long you have to wait for an ultrasound if you don't have an ultrasound readily available. I think that's a phenomenal idea in terms of figuring out your cost efficiency. But yes, having an ultrasound available right when you need it, I think is going to change our anesthesia practice.
so one of the other areas that, where there's great utility but not often talked about is cardiac. And there's a whole host of patients done urgently where you don't have the quote cardiology clearance, where you actually have all that cardiac information, particularly in a trauma situation, but in others that's there. Plus, in that rare circumstance where there's cardiac arrest, there is great data on the value proposition of ultrasound to guide, the management of CPR and therapy within a cardiac arrest. What do you guys do in the world of cardiac ultrasound, and how are you teaching your guys on how to use it to make quick assessments of whether it's left ventricular function, whether it's wall motion abnormalities, pericardial effusions, all the myriad of uses? Where do you see the role of cardiac ultrasound in anesthesia?
I think Ron sees a lot more than that than I do.
Yeah, so I can answer that. There's various different anesthesia models, right? So I'm blessed to work in a location where we have our trauma surgeons, our emergency medicine, trauma residents, critical care, and so there's always a myriad of people taking care of these patients, and so there's certain skill sets that some have that others don't necessarily have. Anesthesia is usually at the head of the bed, managing the airway, managing breathing. We often have the trauma team managing the rest of the patient, and particularly looking at the fast exam and extended fast, looking at the heart. But that being said, there are circumstances, especially when we roll back to the OR, and now the surgeons may be working from the belly down, where we could stick a probe on and sort of look at what the heart's doing, look how the lungs are functioning. In my particular, and then there are other anesthesia practices where, there's good reports in the literature of using ultrasound in the prep center, looking at, preoperative cardiac ultrasound. What I think what I think happened over the last 10 years, and I credit the American Society of Anesthesia for this particularly, is that we've moved from a model where there are cardiac anesthesiologists that do TEEs, and they literally do a very comprehensive exam, right? To a model in which even the regional anesthesiologist could look at the heart and make some binary, questions answer those questions. Is there significant pericardial fluid? Is there significant congestive heart failure? Is there significant aortic stenosis? So very simple binary questions. And they developed an ASA POCUS cardiac exam, which is pretty straightforward. You can learn it. I went through the course. I became ASA POCUS certified in cardiac, in lung, in gastric, but particularly in cardiac, even though I'm not a cardiac anesthesiologist and I can't answer very significant questions. But for my trauma patients, if a patient is hypotensive, knowing whether or not they have fluid around their heart, whether or not the heart's pumping appropriately, whether or not there's aortic stenosis, will change some of my management in terms of how I'm taking care of this patient, whether they're significantly hypovolemic, are they bleeding somewhere else? So it does give you important information, but keeping it simple. If you're already a cardiac anesthesiologist, that's a whole different level. But keeping it very simple is a great tool to have to be able to identify what's going on in the PACU, what's going on in the OR, or preoperatively if you're concerned about whether or not you're going to put more monitoring on this particular patient, if you're going to give them a fluid bolus, all those kind of details. It's been very, very helpful.
I'll give you a quick case example of that. Probably about 7 years ago, I was working at a surgery center in Northern California. I had a 70-something-year-old lady having a right shoulder procedure done, rotator cuff, whatever. And about 40 minutes into the case, her pressure just dropped. And I couldn't figure out why, just because she was cruising along. And I asked the surgeon, did you guys do something? Because, of course, it's always your fault, John. You guys pressing on a carotid. They're like, no, we didn't do anything. Did you use a lot of blood? No. And I had my ultrasound. So I slapped it on her chest under the drapes. And I saw that her ventricles were just completely empty. So she just got to that critical point where she was volume depleted. She was able to hold her own until she, either lost enough fluid just from the surgery and everything else that it just hit that critical point. Like, when do you have the heart attack? You don't slowly have that heart attack over 6 days. Eventually that one little platelet clots it off with a plaque. It was that same thing. So when I saw that, I realized I was really behind on fluids, way more than I anticipated. So I gave her some pressors to get her pressure back up to make sure we had perfusion in the interim. But now I knew that my fix was giving more fluids, and it wasn't just keep pounding them with pressors and flogging that empty heart. So there are circumstances, just like Ron said, you don't need to be a full-fledged cardiac anesthesiologist. You can answer, point of care ultrasound. We teach the residents, it's yes, no. You're answering yes, no questions. You're going in with an answer. Is this stomach full? Yes, no. Is this heart full? Yes or no? Is there a pericardial effusion? And even in the routine orthopedic, podiatric surgery center where you're doing what most people consider simple cases, you're going to have those patients that will just defy you to do a good, safe anesthetic. And the ultrasound is a tool you can have in your hand. You don't have to wait for it, put it on the patient, and hopefully get the answer to that question in a matter of seconds and not minutes.
Yeah, I think of those situations, and I really, hope to see anesthesia do more of this, because at the end of the day, there are 3 kind of quick things for me. What's their volume status, and actually looking at the heart itself, and then what is their contractility, general terms. You can tell when a heart's not contracting when it is. You can tell when it's empty or when it's full, and you can look whether at the IVC or the IJ. And then the third thing is look for critical AS, because not everybody's actually good at recognizing what that murmur's from, because critical AS will burn you and burn you badly with an anesthesia event that you don't get them back from. And so I think that's the other one that I think, get a quick look, get used to knowing what a calcified aortic valve looks like. You don't have to do all the crazy measurements. You can just get a sense, do they have a bad stenotic aortic valve or not? And that'll be incredibly helpful when somebody gets hypotensive to know what to do, because you use different agents. You guys know that. And it affects your decisions. I think at the end of the day, when you can do something and use technology that will affect your decisions, it should become a routine part of what we do. And I think that the cardiac one's another one. Well, you also mentioned lung a lot. Do you use lung ultrasound to look at your patients postoperatively because we know you guys never give too much fluid. You know, that never happens with anesthesia. But
I've never done it.
never
Never done
once.
it.
But somehow they manage to get short of breath in the recovery room and their pulse ox starts to drop. The reflex is always a chest x-ray, but is there a role for ultrasound in that? Maybe not necessarily in the operating room, but afterwards.
I'll jump in quickly because we did briefly discuss this. I think some of it is not only institutional, it's also regulatory. So I think remember at an ambulatory surgery center, not a hospital outpatient department, not an emergency department, at an ambulatory surgery center, you cannot get x-ray after a procedure if it was not part and parcel of that procedure. So if you're putting a pacemaker in, if you're doing ureteral stents, if you're doing something that requires radiological services during the procedure, that's okay. But you cannot get a belly film to see if you perfed during your colonoscopy. You can't get a chest x-ray to see if your ENT surgeon tore the pleura when they were doing that rib graft. And that happened back in 2015, where CMS changed the rules to try and prevent some of these riskier cases from happening at an ambulatory surgery center. So if I do have somebody, if I have a patient who had a lap chole, a laparoscopic hysterectomy, and now they are getting chest pain or short of breath, I don't have any other option. My ultrasound is my only option. And you will see that where sometimes they'll blow a hole through the diaphragm and get some of that subdiaphragmatic air that's going to get in there when they're doing the lap chole, or they already have a rent in there that nobody knew ahead of time. So in an ASC, a lot of times the ultrasound is your only tool that you have and can help you make that decision to transfer, not transfer, or to watch.
The other thing I would add to that is, something we haven't really spoken about is the software platform of where these images live, right? So a lot of times what we're so used to is, listening with breath sounds, but that's not recorded, right? So you don't know what it sounded like an hour ago, especially in someone else's ears versus how it sounds now, and I think with ultrasound, what I've seen is that people love this tool. It's great technology. But a lot of people still in this institution outside of anesthesia don't necessarily save their images. They don't save the recording. And that, aside from the medical legal issues, it is just a mistake because forget billing, forget medical legal. It's just a matter of being patient centric. This is what the patient looked like before. This is what their heart looked like before. This is what it looks like now. Fast exams are serial exams. Patients might not have had a positive fast 15 minutes ago, but now might have a positive fast because the bleed is becoming, more significant. So for me, particularly, it's a function of being able to use ultrasound and then look and saving those images, having them go to the network, having them go to the cloud, accessible to everyone on their phones, on computers, being able to log into the Butterfly network or any other network that you have to capture those images. All of our images also go to PACS. And being able to look at them not only for quality assurance to be able to say whether or not the exams were correct or not, but being able to see the trend and see whether or not some things actually changed. I think ultimately we're going to get a lot better at that, especially when it comes to artificial intelligence and AI being able to dictate and being able to compare things of what it was. The only way we're able to do that is if we do the exams serially. And that's I think it's going to make a big difference in terms of our patient care if we recognize that these are actual patients that have a dynamic presentation of what's going on with them.
And I think the follow.
Yeah, go ahead. Tom.
I think the follow up on that is on research as well. You see a lot of these studies, especially in anesthesia, where they're comparing medications for blocks. Does this agent work better than this agent? But how do you know the person doing the block is any good at it? So unless, and we are seeing this small but significant trend in a lot of the research where some of these different places are using third-party verification where they're actually saving every image, whether it's a tap block or a PEX block, to say that I was actually in the right space. Ron was saying you're in the arterial line, yes or no. How do you know you're in the right spot when you're doing a tap block? How do you know you're in that subpectoral fascia when you're doing your PEX block? So if you're not saving that image and then sending it to a completely, hopefully somebody who's unbiased third-party person to say, oh yes, this block with your needle was in the right spot. Now you're trying to compare medications, which has a lot of financial implications for the pharmaceutical industries and also for universities, when you may not even have the same success rate. Maybe 20% of the time, your needle's not in the right spot. So I think we're going to see ultrasound become a third-party verification become ubiquitous in research within the next 5 to 10 years. I'm just going to throw that out there. You heard it first.
Well, I think the call to save images is incredibly important in so many different ways. The first of which is, if you're saving the image, people are going to be a little bit more fastidious about getting a good image and making sure that they're, because you're putting candidly ourselves out there. This is what I got. That's number one. Number two, I think the longitudinal data becomes critical in what we're doing, and to be able to compare that going forward. And then the last thing for me is how do we learn from what we did or didn't see? I mean, I'll tell you this as a vascular surgeon, I read pulse exams on people's charts all the time. And I can flat out tell you, even though they document it, I can't begin to tell you how many times I say, well, palpable pulses in the feet. And I got an occluded aorta, and both iliacs are occluded and the SFA is occluded. I'm sorry, but there's not a palpable pulse. But there's no way to kind of validate that. But with ultrasound, we can. And we can get better, and we can learn from what we've done, and we can be better doctors because of that. So let's shift in the last few minutes. How do we build a program? How are you looking at building a program at your institution? What advice would you give people about structuring, if you will, the use of point of care ultrasound in an anesthesia program, both from a training perspective, ongoing quality assurance and management, and maybe from the billing perspective to make sure that you're keeping up with all of that? Maybe both of you could take a shot at how you've gone about doing that at your institutions and what advice you would give.
I can tell you from my own institution here in Maryland, one of the first things we started doing was recognizing that, we need to store these images, but we need to get them stored and documented in Epic and PACS and be able to look at them. So the important thing for me, particularly, especially as I was building both the ultrasound guided regional anesthesia program, vascular access, but also the diagnostics, again, cardiac, lung, gastric, and fast, which is, again, those particular certificates that the ASA provides, is looking at their exams, looking what the ASA was asking us to do, and then building that into our worksheet. And so the worksheet that we built happens, again, to be Butterfly Network, was the exact worksheet that if a person wanted to become POCUS certified from the ASA in lung, for example, they would have to answer the exact same questions in their exam as they would on the ASA POCUS certification. What this did is it automatically required our trainees, especially those who wanted to become POCUS certified from the ASA, it automatically train them that they would have to follow that exact questions and protocol that they were being asked from the ASA. We did that with cardiac, we did that with lung, we did that with gastric, we did that with fast. And so we built a program in which it became super easy. If you're doing exams on these patients anyway, you have the model within your Butterfly or your software system to be able to become certified. And you had other individual sort of mentors looking over, as Tom mentioned, quality assurance and ensuring that they were getting the right images and the information that they were diagnosing were correct.
And I think it's threefold. Number one, you have to have ultrasounds available. So like Ron was saying, there's still a lot of providers. I got to put this A-line in, and I'm calling the anesthesia tech and I've ultrasound, screwed, I'm just going to throw the A-line in. The second thing is you have to have an ultrasound that's not 100 years old that can actually capture an image and make sure it gets uploaded into your system. To be able to bill for it, even though the insurance companies are not going to always ask you for the image, if they ever do an audit and you don't have the images, you're going to owe a lot of money back. And the third thing is to have an integrated system, just like Ron was saying, where the order can be placed, the image can be saved, where the providers don't have to do a lot of extra work. Unfortunately, most providers aren't as energetic, let's just say, as I would like them to be. And that's a lot of extra steps. Anything that can automate that, to have the order placed, have the patient's MRN information readily available, and be able to click, boom, I can bill for that. So I think a lot of universities, especially as a lot of private practice, are leaving an incredible amount of money on the table by simply not having that background software, just doing that extra work up front to be able to have something to immediately capture that image for a central line, an A-line. We can't bill for gastric ultrasound at present because we're not doing a full stomach gastric system. But for me, that one case I saved, not having 4 hours, that efficiency, and then keeping my surgeons happy, keeping my GI providers happy. I think in the ASC setting, you have to remember that a lot of our surgeons and our GI docs, they're owners in multiple surgery centers. So I need to be the path of least resistance. I need to be the one who is the one not canceling their cases, not because I'm going to put patients at risk. A rapid sequence induction is not a benign procedure. I think Ron does it brilliantly more than anybody I've heard in the last 30 years, but it's not a benign procedure. And in the learning institutions, we don't always have the most skilled laryngoscopists putting that tube in those difficult situations. So all of those things come into play. And that's why I think having an ultrasound that is available, that is easy, where your ROI, and I don't talk about ROI, I talk about your ROY. When I go to our administrators, here's why I need this, because I'm going to cause you a 2-hour delay for that gastric case that's going to cost you $400 in extra time for your staff, and it's going to upset everybody else in there. That's why I need this ultrasound. That's why I need this thing in my practice. Because the administrators will always tell you, oh, we care about patient satisfaction. We care about all these things. It's about money. Can you bring me more money? Can you save me money? Do you have a service that will bring more money in? And that's what the ultrasound does for us.
What are the most common CPT codes you bill, and what's your typical reimbursement?
For us, it's going to be the nerve blocks. Obviously, some of those got integrated back 2 years ago. CMS integrated the use of ultrasound into the nerve blocks. You still have to capture the image to be able to get for that. I honestly don't have the data anymore. If you'd asked me 5 years ago, I could have told you to the penny what Medicare was paying for a femoral nerve block or for an adductor canal. I don't know that right now. But I know that if you're doing that, if you're taking the risk, and I know that you can still get 1 unit for using ultrasound to place a line.
And Ron, what about you? If you're building your program, is there anything special that you've done differently now that, say, you didn't do 2 years ago? And what advice would you give others that are building a program today on where to start and how to make a program that has the quality that you do?
Yeah, I think what Tom just said, recognizing having ultrasound machines available, being able to scan, having the right mentors, I think is going to be important because, this isn't just, see one, do one, teach one, you watch it on YouTube and you should be able to do it the next day. I think for diagnostics, there is a fair amount that needs to be done. People have to train, and you have to put in the time to learn the anatomy, to review things, to try and solidify. So having somewhat of a curriculum for those that are interested in doing it now, as Tom mentioned before, also there's a ton of resources online. You could probably, use some of those resources to train yourself, but you have to scan. And then, like you mentioned, and what we did again, what I said is that if you build worksheets, if you build the documentation where someone is required to not just put the probe on and then they're done, but rather go through somewhat of a more comprehensive exam to be able to answer a bunch of questions, that's going to be able to train you so that when you have to use that exam later on in a different patient, you already have known how to do that. I think, we tend to use it pretty quickly, but the more you do it and the more you do some of these diagnostic exams more comprehensively, the more you're just going to get very comfortable with all the anatomy and all the potential, anatomical variations or pathology that exists, and then you could, feel very comfortable with it.
Well, this has actually been really, really good. I really love what you guys have shared, and I'll give you my opinion, and you guys can. I think the onus is upon us when we decided to take that oath to become physicians, to be the best physicians we possibly can. We owe that to every patient that lies down on a table in front of us because you think about this. I think one of the most amazing things that happens in the field of medicine is people know us for about 5 minutes and then put their lives in our hands. It's a remarkable responsibility that they pass on to us that we should have it. And I think the onus is on us to be the best doctors we can be. I am hard pressed to understand how you could be the best doctor you could be if you don't have this skill set, because I think the data is overwhelming that if you have the ability to use an ultrasound and add it to the way you practice medicine, and whether it's the myriad of use cases that we've talked about today, whether it's the stomach, whether it's the lungs, whether it's lines, whether it's regional anesthesia, whether it's checking the airway, you're a better anesthesiologist if you're facile and have a probe in your hand taking care of patients. And I think that is the challenge to everyone across the country. And I think anything short of learning that, you're making excuses and you're selling your patients short. You guys are obviously incredible examples of what people should aspire to be. I'm very grateful to both of you and would welcome any parting comments either of you had, and we'll close this down. And I'm sure people got a chance to learn a lot tonight.
I'll take my parting shot with trying to answer that GLP-1 question. Do you perform gastric ultrasound for all of the patients on GLP-1s or for those who can't be rescheduled? In the last year, I have canceled one case for a patient who did not stop their GLP-1 for a week, and it was a lady who had fasted for 2 days and did clear liquids for 24 hours beforehand, came in, had taken her GLP-1 3 days earlier. So I scanned her and saw some late solids. It's the first time we said, we're not going to proceed because she was very tiny. We actually had her do clear liquids one more day, come back the next day, scan her, and completed her procedure. So I hope that just by having the universal ability to scan these patients, that we go away from just because you took your GLP-1, it's in that first 4 months of taking it, they're going to have a higher delayed gastric emptying, increased dose. It doesn't have to be a hard stop. You're doing these patients a huge disservice. They've taken time away to have their total joint, to have their spine surgery, and just to cancel them and reschedule them is doing them a big disservice. There's somebody on the other end of that ultrasound probe, and they deserve the best that we can do. And that's using ultrasound every chance that we can to make a difference in their care.
I would echo those comments in the trauma world. I would say that the ability to do regional anesthesia in acute trauma patients. So we happen to be lucky enough as anesthesiologists to be in the trauma base. And we have completely changed, revolutionized the ability to do nerve blocks for these patients who come in with extremity fractures, shoulder dislocations, ankle deformities, where we give them short-acting blocks, sometimes chloroprocaine if the surgeons are worried about acute compartment syndrome. And the nurses are begging for it. The surgical residents are begging for it. The trauma surgeons are now begging for it. We staff it 24/7, but we're not always available to do these blocks because we might be in the operating room. Ultrasound has changed the entire landscape of being able to do nerve blocks in acute trauma patients. And as Dr. Martin said, if you're not using this, you're really you're jeopardizing your own patient. And I think that's what we went into this practice. We went in medicine so that we could take care of patients and help them. And the analgesic benefits of nerve blocks in acute trauma patients has been incredible. And it's only been primarily due to ultrasound's ability to allow us to do that quickly, efficiently, which has helped our patients. So I echo everything that was said. We have to be able to use these for our patients. It's not a function of whether or not we're better. It's a matter of whether or not we're taking care of our patients better.
Well, that's fantastic. Well, I want to thank you both for an incredibly informative evening. I think you've shared a lot of information that will help people along the way. I'm sure you'd be open for people wanting to contact you for further advice. I know both of you are welcome contributors to the field, and I thank you very much for being part of this team. And I thank all of you for listening today. And again, this will be copied and it'll be shared on our website eventually as it goes through the editing. And please share it with others because these guys certainly shared a whole lot of very useful information. And I think that this has been just fantastic. So I want to thank you all very, very much.